Hello everyone, my name is Lucy Kaluvu, and before I start my presentation, I'm an NIHR doctor from a research fellow, and I'm also a third year PhD student with LG University. I just give my background. I'm actually a general dentist by profession, but I went into postgraduate training in public health, and the opportunity to be here in health analytics is actually something that is great for me because I'm actually taking my baby steps towards being an analytic, someone who's doing health analytics. So I hope you bear with me. My study is on multimorbidity and socioeconomic deprivation and its effect on health utilization in the northwest of England. And I'll be using the combined intelligence for population health action data. This is a data set that has recently just been developed since COVID-19, and actually they brought out Open Safely during the introduction lecture, and they're actually a bit like cousins, the same platform. Just to tell you about what I'll be talking about is multimorbidity. This is the coexistence of two or more long-term chronic conditions. And I know people are always like, so many researchers are talking about multimorbidity. Why do we need more research into this topic? And the reason for this is that you find that although multimorbidity is the coexistence of two or more long-term chronic conditions, with the introduction of mental health conditions, it's actually changed the dynamic of multimorbidity. And you find that it's no longer a condition that's affecting older demographic, aged 65 years and older. We see that now the younger demographic is starting to develop multimorbidity. So this helps researchers come back to the table and ask themselves, is there more that we need to do with regards to multimorbidity? And you find that a niche in socioeconomically disadvantaged area is something where we have seen the onset of multimorbidity becoming higher, 10 to 8 years as compared to patients who are living in less socioeconomically disadvantaged areas. So these are one of the reasons why multimorbidity continues to be a topic that researchers are exploring. So when I go to the next slide, you want to find out why is multimorbidity so important to the healthcare service. You find that a lot of studies have looked at general practice consultations. They have also looked at secondary care. This is looking at acute emergency care, looking at inpatient hospitalization. But there's the concept of social care, which is long-term care that involves domiciliary care and aid in activities of daily living. And these are the basic things such as brushing your teeth, taking a bath, walking up a staircase. And you find that although coined as long-term in other countries, now in the UK, social care is something that is becoming very prominent. And the interaction between health and social care is something that researchers are now trying to understand. Where can we come in, do more research, and try to see how we can create evidence-based recommendations that can involve the care of multimorbidity in that perspective. And you wonder why I'm here. Today I'm here in terms of social care referrals and social care services. Not that I do not like GPs or I do not like secondary care. It's just that I feel that with the unique opportunity to interrogate the combined intelligence and population health data set, which is an integrated health and social care data set for over 2.5 million residents of the Cheshire and Merseyside integrated care footprint. It's a unique data set that has now come in with linked data from local councils. And this is why I'm here today to give you an experience of how social care and multimorbidity are interrelated. If I go to the next slide, I'll introduce you to St. Helens. It's a small socioeconomically deprived area with around 184,000 residents. You may wonder, why is it that we are so focused on the north? You find that there are incessantly poorer healthcare outcomes in the north compared to the south. And the north-south divide is something that is there, it's evident, and it's something that we need to think about. And you find that a lot of research has been done in southern regions, and we have also noticed that life expectancy and mortality rates are actually lower life expectancy and higher mortality rates have been seen in the north regions compared to the national average. And this helps us to understand that it is important for us to also focus on regions in the north. My study setting is St. Helens, and as you can see, according to the 2019 Index of Deprivation report, it actually dropped down from 36% to 26% in 2019. And it's one of the areas that I have been focusing on. If I go to the next slide, I'll introduce you to the CIPHA data set, which is the integrated health and care social care data set. As you can see, it holds 2.5 million records for Cheshire and Merseyside, but I was interested in interrogating the data set for 184,000. And it contains information ranging from demographics, GP events, locally sourced A&E. It has acute accident and emergency, inpatient information, and the data set that I did want, which is social care. And social care has been provided in such a granular way where we can see social care events, alerts, disabilities, classifications, practitioner information, and this is all coming from the local council. And it's a very good opportunity to be able to see how health and social care are coming in together. So as you can see, for my data set, I've been able to give some descriptive statistics and also explore some key relationships with social care. When I go to the next step, you want to understand how am I measuring these conditions. The Johns Hopkins ACG system is a system that has been used extensively in the US, and it's also come to the UK. And you find with the ACG, compared to the other measurement system, it actually creates a morbidity profile for the patient. It looks at the duration of the condition, the severity of the condition, the etiology of the condition, and also the specialist care, and groups patients into what we call aggregated diagnostic groups. And these groups come in 32 categories. And once we link age and gender to that group, we create what we call an ACG. And that is what is defined by the ACG system. And you can see GraphNet Health, who are the administrators of the CIPHA data, have used the ACG system to be able to take healthcare information, put it in a way in which we can identify long-term chronic conditions for the patient, and also use it to mark specific healthcare outcomes, such as unplanned inpatient stays, the social care flag, which counts the social care interaction, and also emergency visit count. So this is the ACG system, and that is why it's important. It's been introduced to the UK system, compared to other nationally representative data sets such as CIPHA and SAIL, where they've been able to use other different measurement systems for long-term chronic conditions. You find that the ACG system is becoming something that is being accepted more. And the fact that it has also been used in the US is something that helps us see that it has worked there, so it is also working here in the UK. When I go to the next slide, I just want to introduce you a description of the CIPHA data set. That's 184 patients. Today, I'm just going to give you generals, because the thing is, with this data set, it has not been interrogated before. This is data that has been held since the inception. This is April of 2019, when COVID-19 occurred, all the way to 2023. So this is a very new data set, different from the CPRD and SAIL data sets and other nationally representative data sets that you see. So you can see that we've been able to find that around 33.8% of adult patients have one or more long-term chronic conditions, and the highest number of long-term chronic conditions is actually 29. And we've all been able to see that the prevalence of multimorbidity is around 29. I just wanted to give you a snapshot of how the data looks like within this system. What is so different about this system is that this data is stored within the SQL server. Today we were asked who has been able to write a SQL query. This was my first time writing a SQL query. And as I tell you, I'm a dentist turned into a public health person and now an analyst writing SQL queries. So I had to be able to derive that data from an SQL data set and to an SQL server and feed it to Stata to be able to analyze it. So these are some of the snapshot information that we've been able to get. From this, you can tell that our prevalence is around 29.1%, which the last time they were able to get prevalence of multimorbidity in this region was around 2019, before the pandemic. So this is new information that we are adding on to our data. And you can also see the age group of 18 to 29 years is showing that actually young people are developing multimorbidity. And some of the questions we need to ask ourselves is, why is it that young people are now showing having one, two, or more long-term chronic conditions? What are we missing? Because we'd expect that 60 to 69, all the way to 80 years would be the patients who are presenting with long-term chronic conditions. And I just want to show you two important figures that I was able to create. The first figure is showing the long-term condition count and also looking at the different age groups for the patient. And you can see as the age group as the patients are moving towards the older age group, you can see the number of long-term chronic conditions are also increasing, and the percentage of patients are also increasing. But what I need to point out to you is that you can see at the age of 0 to 9 and 10 to 19, there is an aspect of multimorbidity that is being seen there. So you see that young people are actually developing multimorbidity. And you find that risk factors such as obesity and other factors such as smoking are some of the things that the younger people are adapting, and they end up developing long-term chronic conditions. And by the time they're entering their working age, they have developed non-communicable diseases, and also the combination of mental health conditions such as mixed anxiety and depressive disorders. If you go to the next diagram, I've been able to look at socioeconomic status using the index of multiple deprivation, which looks at the deciles of the different areas based on the 32,000 lower service output areas. So it's able to categorize all the regions from 1 to 10, and 1 being the least and 10 being, 1 being the most deprived and 10 being the least deprived. So you can be able to see that the trajectory of multimorbidity is increasing. Here we're just able to show you how the number of long-term chronic conditions are increasing based on the age groups and based on the gender. And you can see females are actually having a higher long-term chronic condition count. Since my time is winding up, I just wanted to come here and show you some of the preliminary work we have been able to see. These are some of the conditions that are coming out as being the most frequent within the multimorbidity population. And you can see mixed anxiety and depressive disorders are actually coming up, showing us that mental health and physical multimorbidity is something that is becoming an issue within the demographic. And you can see it's also pushed down other conditions, and you can see depression and anxiety are up there. When you go to our social care analysis, since my time is winding up, I'm just going to give you a snapshot of what we have found within social care. We found that a lot of people are having self-referrals and referrals from GPs, but there's a challenge with our social care teams and occupational therapy. So this begs the question, is there something we are missing in terms of the transition of patients from the GPs all the way to the social care team? And if we go down to disabilities, which is the last part I wanted to show you, mental health and cognitive disabilities are something that we are seeing, meaning the message I want you to take forward is that physical mental health multimorbidity is something that is becoming very prevalent, and it's something that we need to interrogate more within the data set. And we are also seeing that other disabilities are being pushed down, but mental, cognitive, and autism and Asperger's, which are prevalent mental health conditions, are quite significant. I think I'll just go and leave you to read that as my time is over. But the main message, as I've put it in blue, mental health conditions are becoming a challenge, and the use of a linked health and social care data set is our first step towards looking at the integration of health and social care services within our populations. Thank you.